name's Dan Lubman. I'm the director of the Monash Addiction Research Centre at Monash University, and it's my pleasure to introduce you to the final webinar of the year, the role of peer support in treatment, the latest on research and practice. Let me just start by acknowledging the traditional custodians and the lands on which we work today, and pay my respects to elders, both past, present and future. The aim of the webinars, the Monash Addiction Research webinars, are to bring together addiction researchers, clinicians and other experts from the sector to discuss emerging research and challenges in the addiction field. And this will be our final webinar for 2020. So thanks so much for everyone who's been with us over this last part of the year. All the webinars, whether you can make it in person or not, are recorded and are available on our website. So please make sure, if you've missed any of the webinars this year, please check out the website and please enjoy those. And if there's any talks that you think other people should see, please feel free to promote those talks to a broader audience. Just before I introduce today's speakers, I just wanted to flag a couple of issues. One is, I think everyone will be aware of the Addicted Australia documentary that's currently airing on SBS, and absolutely delighted to have Heather and the team here who were critical in supporting that project and provided the fantastic family program that many would have seen on Tuesday night. So if anyone is living under a bush and have not heard of this series, please check it out on SBS. It's on every Tuesday at 8:30. The first 2 episodes have just aired and we've got 2 more episodes to go, and it's available on SBS On Demand. If you have any commentary around it, please share the conversation, join the conversation, make comments on Addicted SBS. Really a great opportunity for us to increase the conversation nationally around this important issue. And please, if anyone you know who is not aware of the work that we do in this sector, or you think would be informed and have a better perspective on what we do, please encourage them to watch the documentary, because I think everyone who's seen it can agree, it really sort of presents a very humanizing picture of addiction and helps explain all the work we do every day in terms of meeting people where they're at. As part of the Addicted Australia campaign, we've brought together over 35 organisations now from across the country to create a broader campaign called Rethink Addiction, rethinkaddiction.org.au. This includes both partners within the sector and outside the sector, including Ambulance Victoria, including the medical colleges, the AMA, and a whole range of other key supporters who intersect, every day with people who struggle with alcohol, drug and gambling issues. We have a number of unions on board, and the list of organisations is growing. So please check it out. 2 key things to ask people. One is around promoting the campaign and promoting the petition. So we have a petition essentially which calls for a national plan, a national roadmap for addiction, to make addiction a national priority and create a dedicated research fund. So please check that out. And if you're happy to support it, please sign the petition and get as many of your friends and colleagues to sign it as well. And also there's an opportunity to share stories. So we have, the courageous 10 participants on the documentary sharing their stories. And really we want to use this opportunity to sort of create, the really important messages of hope that we know that that's out there, and want to challenge that prevailing stereotypes and stories that we see in mainstream media. So please feel free either to read those stories or to share your own story, be that for your own personal experience of addiction as an individual, a family member, or a clinician working in the field. On that note, can I now introduce our fantastic speakers for today? We have, kicking off for us, Associate Professor Victoria Manning, who's Head of Research and Workforce Development here at Turning Point and at Monash University. She is a chartered psychologist and holds a PhD in neurocognition and co-occurring disorders. And over the past 2 decades, she's worked as a clinical researcher in addiction in the UK, Asia and Australia. Her research portfolio includes clinical trials, intervention studies, training and prevalence, and treatment outcome studies. Following Vic and her fantastic talk, which I'm sure you'll enjoy, we have a double act from SHARC, two amazing national leaders in this space. Heather Pickard, I'm sure all you know, is the CEO of SHARC. Following a personal experience of recovery from addiction, Heather has directed her career as a registered nurse towards the alcohol and the drug sector, working in outpatient residential withdrawal. She established a hospital liaison team, advising hospitals in building capacity for acute presentations, and later founded the Nurse and Midwifery Health Program, which met a need to address the well-being of nurses and midwives. Since 2006, Heather has been the CEO of the Self-Help Addiction Resource Centre, a sector leader in lived experience AOD work with varied programs covering service user advocacy, family counselling, supported residential recovery and peer workforce development. She remains at the NMHP as chair of the board and recently became board director at Ballarat Health Services. Congratulations on that, Heather. And joining Heather is Crystal Clancy, coordinator of peer projects at SHARC. Crystal has spent the past few years coordinating peer projects at SHARC, managing AODP workforce development initiatives, and overseeing numerous projects aimed at raising the profile and contributing to the expansion of the AODP workforce. Crystal brings a lived experience of addiction recovery to her work in the sector, has a BA in journalism and criminology, qualifications in alcohol and other drugs, mental health, intentional peer support, and is completing a master's in management. Congratulations on that, Crystal. A strong peer work advocate, she seeks to build the capacity of peer workers, organisations, sectors and communities to experience the unparalleled benefits inherent in lived experience work. And it's an absolute privilege to have you both here to tell us all, what are the secrets of doing peer work? What do we need to think about and embed it in our treatment system? And what are your tips and strategies around that? So I'll hand over to Vic, who's going to give us the evidence and some of her key learnings from a number of projects that she's been involved in recently. And then Vic will hand over to Heather and Crystal for their presentation. If people just look at the bottom of the screen, there is a Q&A box at the bottom of the Zoom. So please don't ask questions in the chat section. Please add them to the Q&A section. And at the end of the presentations, we'll come back and we'll ask those questions directly at our three speakers. So on that note, can I please hand over to Vic?
Sure, right. Can you see the screen? Can you see that yet? Great. Okay, thanks, Dan. So what do we mean exactly when we're talking about peer support and mutual aid? Well, we're talking about the process of giving and receiving non-professional, non-clinical assistance between people with similar conditions or circumstances. And often that involves the exchange of knowledge, experiences, encouragement, emotional or practical help. And it's a critical component of the AOD treatment system, be that from peer workers with lived experience as part of the workforce, or mutual aid and self-help groups both during and after treatment. It's a free and widely available form of aftercare where the focus is really on improving and maintaining the gains that people make during treatment and attaining those broader life goals. And that could be improved well-being, family reunification, employment, for example. So the logos that you see there at the bottom of the screen, they're some of the more commonly established forms of mutual aid or self-help groups. So we've got AA that's now been around for 85 years. They run about 18,000 weekly meetings across 180 different countries. There's NA, which has been going for around 70 years, 70,000 weekly meetings in 144 countries. Smart Recovery, which stands for Self-Management and Recovery Training, that's now been going for around 25 years. Delivering around 3,500 meetings a week in 25 countries, as well as other sort of secular organisations like LifeRing and Women for Sobriety. But it's been such an incredible area, such an exciting area of growth, I think, in the past few years. I was very fortunate to be a guest editor on this special issue in addictive behaviours earlier this year, a special issue on mutual aid and peer support, along with Peter Kelly and Amanda Baker. And this was great because in the submissions, I got to read them all, and that really was an eye-opener in terms of just how much it's evolved and expanded. And I mean that in terms of where it's delivered, and particularly with community recovery organisations and recovery support programs that have taken off in the US, in terms of how it's delivered and the reach that telephone, online and teleconferencing platforms afford, and of course online forums, and also who it's delivered by. So whether that's paid or volunteer workers, there were examples of parent-to-parent, telephone-based peer support, and also who it's intended for, including some priority underserved populations such as pregnant women with opioid use disorders and those working in the harm reduction area. And it's fair to say that whilst it's early days in terms of the scientific rigor of a lot of the research on these new and emerging forms of peer support and mutual aid, the results are really promising. But in contrast, the evidence for the more established types like AA and NA has been examined in RCTs or quasi-RCTs for decades. So this year we saw an update of the 2006 Cochrane review on the effectiveness of AA, led by John Kelly. And this pooled the effect sizes of 27 studies, mostly RCTs. So we're talking about the outcomes of over 10,000 participants. And they were essentially looking at the impact of AA, or 12-step facilitation, on drinking outcomes. And they found that compared to clinician-administered treatments like CBT, AA was actually more effective at increasing continuous abstinence at 1 year, and was equally as effective at achieving other alcohol-related outcomes, such as reduced drinking intensity and alcohol-related consequences. Also published this year was a paper by Keith Humphreys, looking at the uptake of 12-step groups among people seeking treatment for drug use disorders. And that review actually pulled the effect sizes from 6 different randomized controlled trials. And essentially it found that whilst engagement was more difficult, or the uptake was not as good in people with drug use disorders compared to those seeking treatment for alcohol, greater attendance still predicted greater reductions in illicit drug use and problems. And a bit closer to home, we did the patient pathway study. And we found that participants or clients in that study that initiated a mutual aid attendance after that first year of treatment achieved high rates of abstinence from their primary drug of concern, and also higher reductions in the frequency with which they were using that drug of concern. And interestingly, it was one of the few predictors, or few significant predictors, of treatment outcomes, especially when they were seeking treatment, when we selected the analyses to those seeking treatment for alcohol. And we also found that the more meetings they attended after that year of initiating treatment, the more MA mutual aid meetings they attended, the better outcomes they achieved. So the blue bar shows the proportion who successfully reduced the primary drug of concern, or frequency of use of that drug, and the purple bar, the number who were abstinent from that drug. So on the basis of this evidence, it's recommended in a number of guidelines and practice documents. The Victorian Department of Health recommends that it should be operated out of community organisations and AOD agencies or community health services. It's also in the National Institute of Clinical Excellence guidelines, and it will appear in the new National Treatment Guidelines for the treatment of alcohol problems. And in this, AA, an assertive linkage to AA, which I'll talk about in a few slides, received a grade A recommendation. Smart Recovery, a grade C recommendation. Other types of mutual aid and peer support groups were considered to have what they call a good practice point. And that's not to say that these are not effective. It just means that the amount of evidence and the sort of designs of the research studies to date haven't caught up yet, but they will. So there's also been a lot of research looking at the mechanisms, trying to sort of identify what are the key ingredients? How is it people benefit from mutual aid? There's numerous reasons, but a lot of the sort of more common ones or significant ones that come out of research can be considered cognitive or social. So on the cognitive mechanisms, we're talking about increased motivation, increased self-efficacy, coping skills. On the social mechanism side, obviously it's very beneficial for people who experience social isolation, exposing people to role models and providing hope and inspiration. There's lots of bonding and group cohesion, but perhaps the most common or what comes up time and time again is really evidence of adapting social networks to ones that are more supportive of behaviour change, and perhaps a reduction in the number of people in their immediate networks who are continuing to use. And generally the social and cognitive mechanisms outweigh any 12-step specific or spiritual mechanisms. So if we know it works, and we know we've got a pretty good idea of why or how it's working, why are there not more people using mutual aid as a free and available form of aftercare post-treatment? Well, there's also been a body of research looking at the barriers, particularly in relation to 12-step groups. And you'll see in the literature that it's commonly reported that many clients may find the religious or perceived religious and spiritual content of groups off-putting, particularly if they're agnostic or atheist. Also, the idea of surrendering, some people are uncomfortable with the idea of accepting powerlessness over drug or alcohol use, and that this may indeed be incongruent or incompatible with some of the core elements of evidence-based treatments that people go through, which tend to center around things like self-empowerment and building self-efficacy. There's also a lot of talk in the literature about misconceptions that, you know, a lot of people may think, well, I can't go unless I'm completely free of all drugs and I can't even take medication. There's lots of misconceptions out there when really the only requirement is a desire to reduce or a desire to stop. And as clinicians are well placed to link clients to mutual aid groups, there's been some research in the UK and here in Australia looking at what are the barriers from the clinician perspective, and often that's around lack of knowledge, being skeptical about, you know, what happens at meetings and what the intent is. Generally, a lack of experience from some studies suggesting that people haven't been to meetings to see, you know, what actually happens, and as a consequence of those, low referral rates. David Best, when he was here, did a study looking at a sort of brief training session with clinicians here in Melbourne, and essentially it was aiming to raise awareness and knowledge among clinicians through a brief education and training program. And that actually did lead to more positive attitudes towards peer support among clinicians and a moderate increase in the number of referrals that they made in the month after training. So it sort of speaks to the, you know, the value of really including recovery and mutual aid training in professional development. So 12-step facilitation I mentioned earlier, this is a manualised intervention that's intended to increase AA participation during and following treatment, and it features quite heavily in a lot of US-based programs. And as well as that, there's been attempts to systematically encourage and facilitate the uptake of 12-step and to explore the outcomes from doing that. And generally, there's been trials of different levels of interventions. Often it's comparing the treatment as usual group, which is simply giving people a list of meetings and saying, here you go, these are ones in your local area, you know, if you want to attend one. And they compare that treatment as usual group to people who receive encouragement from a doctor, and they compare that to a peer-based intervention essentially. And that can either be linking the client with a peer in the community, or sometimes having a peer visit the treatment service and encourage them to go and perhaps share their experiences of attending. And generally, all of these three American studies have shown favourable outcomes if participants receive the peer-delivered intervention. So they were more likely to attend groups and they were more likely to achieve better outcomes. In the UK, we did a similar study where we had a peer visit people during an acute inpatient withdrawal period. We compared that to a doctor recommendation or just the list of where meetings are the treatment as usual condition. And we found that if we could encourage clients to attend, regardless of the intervention they received, if they attended groups during that inpatient withdrawal period, they were more likely to attend post-discharge. Those who attended meetings post-discharge had high rates of abstinence, but they were much more likely to actually attend a meeting if they'd received an intervention with a peer. They were twice as likely than those who were just given the list, although there was no difference in the abstinence rates among those who attended post-discharge between the three intervention groups. And most recently, or since then, there's been a study in Norway which compared a motivational interviewing focused 12-step intervention with some brief advice. And they found that the intensive condition led to higher affiliation, which is a combination of attendance as well as sort of involvement in 12-step, as well as fewer days using alcohol and drugs. So overall, it's pretty positive. So earlier this year, we wanted to see whether it's possible to go one step further and rather sort of just refer people to attend, whether we can actually introduce people to mutual aid groups that they can attend in the community whilst they're in treatment. And so we attempted to embed a mutual aid group in Victorian government funded AOD services. And this was a project but we were funded to do by the Department of Health and Human Services. And I'm delighted to be able to share just a few of the key findings with you today. So we went with Smart Recovery for this sort of demo project for a number of reasons. It's well established, it has fantastic training and resources. It aligns with the strengths-based client-centred approach in a lot of Victorian AOD treatment. The Australian interpretation of smart recovery at least adopts more of a harm minimisation approach, which makes it a good fit. It draws heavily on motivational interviewing and CBT, which most of our clients have had some exposure to, and can be delivered by either clinicians or peers, but ideally both. And so we put a call out to the sector, and we had 20 expressions of interest. We selected 3 sites, and they were Kickstart, which is a programme for men involved in the justice system, Odyssey House, and a regional site, Ballarat Community Health. Because one of the clinicians moved from Kickstart over to Turning Point, we actually ended up with a 4th group. So we trained 10 clinicians or peers working in those services, and I think by the end of the year, everybody was trained. Between sort of December and February this year, everybody had, all those 3 services had started running groups, in-person, face-to-face groups, which was fantastic. But then, of course, COVID came. So March, when the restrictions were in place for any face-to-face contact with clients, and we had to sort of obviously stop running those meetings. We gave the services, you know, the choice, but I'm so delighted. I'm so grateful for the clinicians at these services, the commitment that they had to keep going and to make that transition to the online platform, because not only did it mean that the project could keep going with a bit of a gap in the middle, but it meant that people got access to treatment they wouldn't otherwise have had. So delighted that we managed to keep going with groups. And in fact, by the end of August, we'd run there were 78 groups run with 486 attendances. But essentially what we were aiming to do was, having trained clinicians, supported them to run weekly groups, provided them with resources, was to really to see, do people want this? You know, what's the uptake? What are the attendance rates? Do people benefit? And to really get an understanding of people's experiences from a consumer, facilitator and service manager perspective, and to really try and sort of identify some of the barriers and facilitators to implementing these groups, and to develop a series of recommendations. And so at the end of each in-person smart recovery group, people were given the opportunity to complete a very, very brief survey about how they were travelling and how they found the group. We had 74 people complete that survey, and as you can see from this figure here, almost everybody showed some improvement. In fact, there were a large proportion that were unchanged, but that was often due to them successfully maintaining abstinence from the drug or alcohol for which they were seeking treatment. Very few actually showed any deterioration. On the treatment effectiveness assessment, we saw a shift in the right direction, an improvement on both physical health and psychological health. So 2/3 improved on their physical health and 3/4 on their mental health and well-being. We also saw that 3/4 reported feeling better at taking care of their personal responsibilities and feeling more connected with others after attending groups. Then when we transitioned to the online group, we asked people to complete a survey after the Zoom meeting. Again, it's always difficult to do this. Everybody wants to, you know, shut down their computer screen and go as soon as they can. But we managed to get 30 people to help us out and do the online survey. And this shows that most people agreed or strongly agreed that they were made to feel welcome at the group. They felt supported. They had the opportunity to contribute to group discussions. And 9 out of 10 either agreed or strongly agreed that they, that they want to continue, or indicated that they want to continue attending smart recovery groups, and almost everybody found the groups helpful. Just going to end, if I've got time, to share some of the findings from the qualitative interviews. And I wanted to do this because it really echoes what we see in the literature already in terms of those mechanisms. Sharing and reciprocity, that came out again quite often actually in the interviews, this idea of giving back, of, you know, everybody having something to contribute, bouncing off each other, sharing, whether that's resources, knowledges, experiences. That came through for sharing and reciprocity. Acceptance was another theme that emerged. The idea that, yeah, everybody has something to contribute, feeling nurtured and cared for and accepted. Flexibility and the goal-focused aspects of smart recovery was very popular. The fact that, you know, you may start attending because you want to completely stop drinking, and the group will help you come up with some strategies for achieving that. But if it doesn't work out, next week they'll share that the plan didn't go to plan, and maybe make some adjustments and get some group some support from the group on how maybe they can cut down bit by bit. It's really sort of, there was recognition of this sort of collective wisdom of the group and how that can be used to sort of make these tweaks to people's plans for the next 7 days and foster a sort of incremental progress or a sense of mastery. Affiliation was another sort of key finding. Many of the participants that we spoke to perceived some sort of degree of quality assurance afforded by the fact that groups were connected to reputable AOD services, as if it was some sort of guarantee of the, I guess, of the quality of the mutual aid group. And in this way, it could actually be a way in which we can provide a sort of safe and gentle introduction to these mutual aid groups that are widely available outside of treatment before they transition to community groups. And then just one finding that was probably one of the most pertinent findings, I think, from the facilitator perspective, was that we need more peers. We desperately need more peers to deliver groups. And it's not just a case of attracting peers, people with lived experience. It's also the fact that we need to think about how they're adequately reimbursed, how they're supported, given supervision and training, so that they can keep running groups, because it's really difficult when it's all sort of falls on one person to keep groups going, week after week. So that was one of our key recommendations, that services need to find ways, explore models for reimbursement in the interest of sustainability. So in conclusion, there seems to be, overwhelming evidence that mutual aid and assertive referral can be beneficial. The project I've shared with you today demonstrates that it's possible to integrate mutual aid groups in community AOD services to different populations. There's clearly multiple benefits to clients and services. I haven't had time to share those findings with you today. In terms of future research, we need to catch up with the existing literature that's focused so heavily on 12-step by looking at things like cost benefits, the effectiveness, who it works best for and under what conditions. And I'm looking forward to sharing the report on the Smart Recovery demo project with you soon, because we have a whole series of recommendations to support the wider rollout. That's me done. Thank you. I shall now hand over to Heather and Crystal. Right, I'll stop sharing. That should work now.
Okay. Yeah, good.
Next one.
Okay.
Okay, so lovely to be here and really exciting to hear you, Vic, and so pleased that we're getting some research about the lived experience workforce in its various forms that we see being rolled out. So that's excellent that we're starting to get some research. And I guess what Crystal and I are going to talk about is a bit more of the on-the-ground experience, so research and the practice, the practical elements of it. So just briefly, I think most of you know, but SHARC's been founded on the principles of peer support and mutual aid, and we've been around in different incarnations for about 30 years. We might have had a different name, we might have had different CEOs, but we've been doing this work for about 30 years. And we run peer-based residential services, peer-based family programs, service user advocacy, and peer projects, which include services and workforce development. And SHARC has established peer workforce partnership across a number of domains. And when we first started this work, we thought it would probably be DNA because that's what we were in. But actually our journey has taken us into certainly DNA, but justice, mental health, dual diagnosis services, harm reduction specialty services, and gambling related harm. So that's a little bit about SHARC. And when we talk about peer projects, this is a specifically strategically articulated program within SHARC that we saw the necessity to really start working on the articulation around the peer workforce and what might be the needs. And we currently work alongside the Department of Health and Human Services, and we support the growth, development and the sustainability of the AMD peer workforce. and we are very involved, as are many other sectors, in the stewardship of the lived experience stewardship group at a statewide level, which works across many sectors. The peer projects also does specific work, and it has developed and delivers peer worker training. It still develops and delivers organisational readiness training, and some of what Vic was pointing to before about, you know, the uptake and the support by organisations that's critical to have a successful rollout has been really highlighted to us in our needs analysis. And as a result of that, we developed organisational readiness, and we probably deliver 8 or 9 of those trainings every year. We facilitate a community of practice, and I've got amazing there, because what I think is amazing about that is, you know, we've been working to develop communities of practice across the A&D space for years now in other disciplines, and we've had various levels of success in that. But in the community of practice in drug and alcohol, we have an incredible membership base and real interest from that membership to grow and be part of that. We also recruit, train and support peer mentors in justice and day programs, state-run day programs. And we allspice intentional peer support, which I'm going to talk a little bit about a little bit further down the track. So I guess a lot of people ask us, and as the department did, as we ask ourselves, you know, what is peer work in a treatment setting? And so one of the pieces of work, and Crystal will help me here, but one of the pieces of work that the community of practice developed is most of this data that we're going to be talking about was actually developed by the community of practice. So their definition is a peer worker utilises their lived experience plus skills learned in, you know, strategic training, even more than formal, and to deliver services in support of others. And peer workers offer support to others who have shared experiences by facilitating authentic connections, sharing their personal experiences in a way that inspires hope, offering help and support as an equal within defined roles, and developing positive relationships that demonstrate the power and possibility of change. And Crystal might just give you a little snapshot into the community of practice.
Yeah, sure. Well, the community of practice, the Victorian AOD Peer Workforce Community of Practice, they've been running now for about 5 or 6 years, and the piece of work that you can see, excuse my eyes with the camera and the slides, but the piece of work that you can see up there is developed by the community of practice for the workforce itself, and I think that's what's really cool about this community, is that they're really heavily involved in developing their own workforce and what they do and how they evolve. And I know Heather will speak more about this in a second, but you know, these are some of the things identified as key elements of the work, but how they go about their work, it looks different in different settings.
Yeah, thank you, Crystal.
Okay.
So this is the how of the work. What they do depends on where they're being trained to work in. And I think that's a critical question that we're always asked, and one that it's taken us a while to work out the answer to. We're going to flick over to, there's often a question about the difference between peer work in treatment and peer work in harm reduction. And it was a big elephant in the room, and we've all been through masses of conferences where there, you know, was robust conversations went on. But, you know, we've worked with HR Vic much more closely in recent years and kind of come up with, you know, the peer work in harm reduction specific services have the similar intrinsic value around connection, empathy, street credibility, but the goals they support service users to work towards are different. And peer workers in treatment sector may use words that reflect recovery goals, where services where people are choosing to still use drugs would work on goals about increased health options, safer using practices, etc. But the how, the kind of critical success factors and the elements that sit behind it are very similar. And I think over the years we've got into the trenches about arguing, but really it's about having different goals because the cohorts we're working with have different goals. And the peer workers in harm reduction may still be in a living experience, you know, way of operating themselves. And that's so valid in the fact that they're working with people in the same way. Whereas in treatment, most of the peer workers who work in the treatment space are more focused in their own life to a lived experience story. The harm reduction peer workers, go back, Crystal.
Sorry.
Thank you. Too quick for me. The harm reduction peer workers may sit in NSPs, the primary healthcare initiatives that were set up many, many years ago, which are outstanding. There's some outstanding examples of those still currently, and excellent research by Deakin University about the effectiveness of those primary care clinics for people who still choose to use drugs. Peer workers also exist in the medical supervised injecting rooms and in many of the outreach roles. So I think what I'm trying to say here, the magic of peer work is the same: creating connection, feeling genuine empathy, non-judgment, and creating a non-clinical relationship within defined roles and boundaries. So, you know, we can talk about that for hours, but harm reduction, Vic, and APSU have come to a nice kind of way of seeing that, and it's helpful when we try to articulate it.
Absolutely.
I think it's you.
Yeah, awesome. Well, look, I really want to start to talk a bit about the journey that we've been on in Victoria specifically, but all of this started around 2014 with the reforms, and I know that you were really involved with that, Heather. If you want to just speak to that quickly before I go on.
Okay. I can't help myself because I was so disturbed by it. So we, you know, everybody, most people here will remember the reforms, and we had all kinds of inquiry into what was important for service users. We still ended up completely eliminating peer support from the post-reform model. Really sad. So all the peer support models were defunded as a result of the reform, and some excellent models were potentially created, but it was a very big blow to the peer support lived experience workforce community and services to see that defunding. But I'll just do the lobbying bit.
Okay.
However, what we did was we lobbied in a very active way to try to secure some funding to build capacity across the sector. We weren't getting funding to actually do the pointy end work ourselves, but we got some funding to build the capacity and peer support across the sector, even though it wasn't funded anymore. And it's an interesting journey, and I'll hand it back to you for that bit.
Yeah, it has been a really interesting journey. We started off in 2014 with the peer support capacity building project, and I won't talk a lot about the project, but I'll say a couple of things because, you know, this established 15 groups across all of the catchment areas here in Victoria, and a lot of those are still running today. And I think that points to what you're speaking about that capacity building factor in there. What was really great is that the project was independently evaluated, and these are some of the outcomes that we see from the project. So engaging in peer support groups were associated with a range of salutary effects. Participants reported peer support boosting their inner strength and courage, as well as their sense of control and ability to make changes in their lives. Apart from that, there was some real key findings that helped us move forward. And one of those was that reimbursement, and I know that we saw this in Vic's presentation before, that reimbursement emerged as a factor that could support long-term engagement and therefore sustainability amongst peer leaders. So what we started to see here was that peer work wasn't a free activity, and the sector started to shift to understand that in order to sustain these activities, they had to learn how to fund peer work under the new model.
Do you want me to do that one?
Oh no, that's okay.
Okay.
That's all right. So once that funding was established and people knew how to fund their activities, they saw a need to have a committed committed agency to build and develop and evolve the workforce that was starting to develop. That's where Peer Projects was established, and now today DHS fund Peer Projects to do AOD peer worker training, organisational readiness, resource development. They've just established core competencies for the workforce, and of course facilitate that awesome or amazing community of practice.
And I just might say there that it sounds like we're funded to do a lot. It's actually one position and the rest of our peer projects has been built from generating fee for service in all kinds of interesting places. And I've got to say the incredible goodwill of the sector and desire to be able to fund peer work and utilising SHARC to assist with that and giving us some money to do it, which, you know, has meant that we've gone from 1 worker to 5, which is pretty significant.
Yeah, it's awesome. It continues to grow, as does the workforce. So in Victoria currently there's over 60 positions. I know that the positions are being mapped formally by DHS. They do work in a number of settings, and that's what's really cool, is that peer workers don't just work in treatment and community agencies, they work in justice. They're in the drug courts, the family drug treatment court, they're in emergency departments at hospitals, everywhere where we'll see people presenting with drug and alcohol issues or challenges. Another really cool thing that's been developed is the strategy for the AOD peer workforce in Victoria. That was developed alongside the strategy for the lived experience workforce in mental health and launched at the same time. And that really articulates a way of moving forward with the workforce that's quite strategic, and it's been a really important part of the work that we've done here and in partnership with our allies in mental health.
And I think it's really important to say too that nationally we've seen similar frameworks developed in New South Wales and Queensland. So we're now trying to get a coordinated national energy behind the need to articulate peer work and what are the supports that maximise its effectiveness.
Absolutely, and that consistency, I think, is something that feels important for me, looking forward, that there'd be a nationwide consistency around this, because when we do peer work in an uninformed way, what happens is we come out with these outcomes that we say that peer support doesn't work. And that's some of the challenges that I've seen. But we'll talk a little bit more about the success factors for embedding in a minute. Just a little bit more on the peer workforce in Victoria. We spoke about the community of practice and the core competencies. You know, the guidelines for providers have been developed and published, and they're available, and we continue to contribute to those, and so does the workforce. And, you know, the learnings that go into these guidelines are learnings from agencies themselves that have been doing this for a number of years. And they, you know, what's really cool about Victoria is I know that a number of agencies that have been embedding peer work, agencies that are coming forward to introduce a peer workforce are then leaning on them for support and some mutual learning. So that's great. Senior positions are now being developed, and what's really cool to recognise with that is that peer work is a valuable part of service delivery across the state. It's a new norm, and that's a really nice thing to know and to hear.
And the other thing there, in the past, peer workforces, the senior roles went to clinicians who oversaw that developing peer workforce. And now what we're seeing is that senior positions within organisations are looking for the lived experience lens to manage that growing peer workforce in their organisations. So it's really a good thing.
It's amazing. It's amazing. It's something we've wanted to see for a long time. And, you know, embedding peer work, you know, we talked about, I think earlier, Heather pointed to the critical success factor of embedding peer work in organisations, that readiness and that training. That has been what we've come to see as critical, and that ongoing practice development. It's not, you know, embedding a new workforce isn't something that happens quickly, and it's not something that you do and then walk away from. And it has that continued quality improvement like every other activity that we do in an organisation. So ensuring that that's done. A lot of the work that we've done has been about, you know, helping agencies understand the essence of what peer work actually is, and that the relationship is the primary focus of the work that's done. And sometimes that's really hard to understand, as it often comes into conflict with clinical understandings of how people need support. And it works, you know, it really works. One thing, before I hand it to Heather, just it's important to know that there is a various number of models and training for supporting peer workers, and all of them bring their own benefits. A lot of them can be coupled together and things like that, but it is important that a workforce is trained. I think Heather will speak to one of those now.
Okay, so there's just a few examples. Can we just go back quickly?
Oh, totally.
Yeah. So these are some of the common ones that people hear when we talk about peer worker training. You know, people know SHARC's got a 5-day peer worker training. Peer Zone have a 5-day, peer worker training. Mind have a peer worker training. So they're all good in their own ways. And if we go back to the how we do something and the what is localised in our own environment, then we're not closed to different models but existing. They're actually relevant for where they're established.
Yeah.
I am going to talk a little bit about intentional peer support today. And why are we talking about just one model? And I think the reason why is intentional peer support trainings are funded by DHHS across sectors in Victoria as well as nationally. So it's becoming a really common baseline training where people will do intentional peer support and then move on and do a localised model of training to help them work in the environment that they're based. And one of the amazing things about IPS, it's an American-based product, if you like, and SHARC is actually allspicing the Australian arm of it. But it's a way of expanding our, approach, and it really challenges us and peer workers, and we are lived experience in this space, to see the relationship as a critical vehicle to work with somebody around. It models and positions the relationship as the primary driver of the work. And practice demonstrates IPS works very effectively in clinical settings, provided the supports are in place. And we've seen some examples of initiatives rolled out in mental health over the last 10 to 12 years using IPS, but there was not strategic thought about what other kind of supports are required. And we've actually moved further now in understanding that we also need a localised model of practice that sits on top of this. So I wanted to talk a little bit about IPS because it is a shapeshifter and it is around. And more and more in mental health, we're seeing it as a gold standard in training. But I know that we're going to see some more of this in A&D as we move on, and the team have lensed this manual for addiction, which will be launched in the new year. So it'd be interesting to keep your eye on that space. Thanks, Crystal. Okay, so what are some of the practical benefits of peer work? Again, it expands the scope of work and support that a service can offer. We have seen how this has worked in a number of sectors, as it provides a low intensity, sometimes non-clinical support, and it adds to the range of service types offered. Peer workers and consumer perspective roles are a voice into our service systems that gives us a straight from the source feedback on the server user experience. And look how hard we all try to get that. If you actually start bringing people on board and working in your services, what we see is there's a very direct way of getting somebody who's had a lived experience feedback into that. And, the last bit, if as services we are brave to hear this feedback and position ourselves as equals within roles, we have the unique opportunity to build a richer, more client relevant and helpful service. There.
Yeah.
So I think, oh no, we've got a where to from here.
Yeah, we're nearly finished.
Oh, can I do the where to from here?
Yeah.
Okay.
Absolutely.
Thank you. So where to from here? And there's a point that I need to say before I go into our points is harm reduction services really need to have a funded position to develop their framework like we have had. So I'm a real gun for that. We want to see continued growth, and we will see continued growth. We now operate in 2 of the 3 court systems that we identified we wanted to be in, and we're about to do a submission for the 3rd one. So continued growth. We know that the Royal Commission has a strong focus on lived experience workforce, and we know that the recommendations in February are going to have some articulation and added resource for the A&D workforce in that space. We would love to see an A&D peer worker accredited course, and we would love to see that as a national rollout. And the other thing is coming together across the domains to learn and grow together and be less in the great divide and be more about trying to build knowledge where the river flows between us, you know, new knowledge. It's really exciting. And the other thing is that research is critical, and we need funding to do the research to support this. Okay.
Thank you. Thank
So
you
that's
so
us.
much,
We'll
guys.
hand it back to Kelly or Dan.
Thanks so much, guys. Brilliant presentation as always. We've got time for a few questions. So Brad asks around the rollout of ED crisis hubs. Any thoughts or feedback or experience of P workers in the ED environment? Heather or Crystal?
Yes. I was on a steering committee that was very involved in trying to look at all the different workforce needs in that rollout. But unfortunately, that was stopped due to some issues in the hospital. So we haven't been able to access those peer workers as yet. We're working on that. I think it's a really complex environment, and I think that's one of the environments where it's critical a framework of support is enabled, but we haven't been able to access that space yet.
Can I also, I'll just point out that there is a number of peer workers at Peninsula Health Hospital down in Frankston, and one of those peer workers does work in the emergency department. And I think the idea that they would work in the EDs and the crisis hubs comes from the effectiveness of how that's gone. So maybe linking in with them as an agency would give you some insight.
Maybe.
Thanks for that. A question from Malcolm.